one of it acute suppurative otitis media, and the second one is chronic suppurative otitis media by the second presenter. So here this outline of my presentation today. We have definition, epidemiology, risk factor, causes, stages, signs and symptoms, complication, and management. Okay, next. So by its definition, acute suppurative otitis media is an acute inflammation of middle ear by the pyogenic organism. So pyogenic organisms infection is organism that cause the pus collection, and an acute is what is acute. What acute is acute. So usually if it is less than 3 weeks, we call it acute, and if it is more than within 3 weeks to 3 months, it is a subacute, and then if it more than 3 months, it is a chronic. And another thing is if you want to identify or define the recurrent otitis media, if the 3 or more episodes within 6 months, or 4 or more episodes within 1 year, it is recurrent acute otitis media. Okay, next. Okay, so the acute suppurative otitis media is more common in the pediatric population, in infant and children of especially in the low socioeconomic group, because why they have specific anatomy of the eustachian tube, which are more shorter, straight, and wider compared to the adult one. So the ascending infection from the nasopharynx more easier to the middle ear. And then apart from that, the UTI is also more common for this population, right? So yeah, that it will lead to the secondary bacterial infection, and then the pyogenic organism will invade the middle ear. Okay, next. Okay, now some are the risk factor or predisposing factor to get this ASOM. So anything that interferes with the normal functioning of the eustachian tube will predispose to the middle ear infection. So the first one, it could be due to the infection, which is the recurrent attack of the common cold, URTI, exanthematous fever like measles, diphtheria, or whooping cough, and also infections of the tonsils or adenoids. And second is the inflammation, chronic rhinitis, sinusitis, or nasal allergy, and then tumor at the nasopharynx, and also if the patient with underlying structural or systemic disease also can contribute to the otitis media. So those with cleft palate and uvula, and also with a lower immune system like leukemia, AIDS, and also the barotrauma, for example, in the divers, because of the negative pressure inside the ears, that will leads to the more susceptible to develop acute otitis media. Okay, next. So how actually the bacteria will reach the middle ear is either by the 3 routes. So the first one is either by the eustachian tube, which is the more common in the because the children anatomy, the anatomical structure, and also if in infants or children in the breast or bottle feeding, they feed in the supine position, it also may force the fluid through the tube into the middle ear. So that's why we need to keep the infants prop up with head a little bit higher. And then second one is via external ear if there is traumatic that cause the perforation of the tympanic membrane. And then the last one is by the bloodborne, which is uncommon. Next. So what are the common causative organisms in Western countries, especially during the winter seasons? Acute otitis media is caused by the viral infection, for example, rhinovirus, RSV, or adenovirus. But in Malaysia, it usually caused by the bacterial infection. So the most common one are the Streptococcus pneumoniae, Haemophilus influenza, and Moraxella catarrhalis. And since the vaccination of the Haemophilus influenza type B, so it is uncommon lah. So why we need to know the causative? It tells us to give what are the type of the antibiotic that we need to treat. So next, moving on to the stages or mechanisms of how the this ASOM happen. So first of all, the stage of the tubular occlusion in which the obstruction of the tube is blocked. Second one is the pre-suppuration, and only at this stage the bacteria will reach the middle ear. And next is the suppuration, and if there is a perforation, the pus will come out. And then there's resolution, and then if they are untreated, it can go into the complication. Okay, so we go one by one, signs and symptoms in different stages. Okay, next. Okay, so the first stage, which is the stage of the tubal occlusion. At this stage, what actually happened? There is inflammation of the nasopharynx, so it will cause the edema and hyperemia of the nasopharynx. So that's why it blocked at the end of the eustachian tube. So yeah, it caused the negative intratympanic pressure that will lead to the retraction of the tympanic membrane. So from the symptoms, deafness and earache are the two symptoms the patient will have, but they are not marked, and generally there was no fever. And also from the signs, the tympanic membrane retracted, handle of malleus more horizontal, and then we can see the prominence of the lateral process of the malleus and loss of the light reflex. And if you do the Tuniform test, it will be the conductive type of hearing loss. So yeah, okay, next. Okay, so first we look at the picture. We need to know where is the pus tensa, where is the pus flaccida, and then this anatomy that we need to know. Okay, next. Okay, second one is the stage of the pre-suppuration. At this stage, the tubal occlusion is actually prolonged. So the pyogenic organisms will invade the tympanic cavity, and they will cause hyperemia of the lining of the tympanic membrane. So there will be more blood at the line of the tympanic cavity. So now the tympanic membrane will become congested, as you can see in this picture. And then from the symptoms, the patient might have marked earache, which may disturb the sleep, and it is throbbing in nature. And then deafness and tinnitus are also present, but will only complain only by the adults one. The children may have high degree of fever, and also it is restless. And then, yeah, from the signs, to begin with, there is congestion of the pus tensa. You know, there's the pus tensa at the tympanic membrane, and also we can see the cartwheel appearance, in which the blood vessels appears along the handle of the malleus and at the periphery of the tympanic membrane. And then the later one, the wall of the tympanic membrane, will, including the pus flaccida, will becomes uniformly red. And if in the Tuniform test, will again show the conductive type of the hearing loss. Okay, we're moving on to next step. Next stages. Okay, the suppression. So what happens? Lots of pus. Suppression. Okay, so lot of pus will form in the middle ear and to some extent in the mastoid air cells. And then the tympanic membrane will start bulging to the point of the rupture. So in the symptoms, patient might have earache, will become excruciating, deafness increase, high fever, vomiting, and even convulsions. And then the signs, what will you see as a doctor? The tympanic membrane will appear red and bulging with loss of the landmark. Handle of the malleus may be engulfed by the tympanic membrane and may not be discernible. And a yellow spot may be seen on the tympanic membrane where the rupture is imminent. Okay, next. As the tympanic membrane rupture, then it will release pus. So at this stage, all the symptoms will subside, and then the inflammatory process will begin to resolve. So if the proper treatment is started early, or if the infection was mild, the resolution stage may start even without the rupture of the tympanic membrane. So for symptoms, all the symptoms will gone, the earache relief, fever will come down, and the child feels better. And then from signs, the external auditory canal may contain blood-tinged discharge, which later becomes mucopurulent. So usually a small perforation, a small hole, is seen in the anteroinferior quadrant of the pars tensa at the tympanic membrane. And then the hyperemia of the tympanic membrane will begin to subside and then return to the normal color and landmarks. Okay, last. So lastly, what will happen if the resolution is not occurring? So, because the virulence of the organism is highly high, right? So the resolution is not taking place, and then the disease will spreads beyond the confine of the middle ear. So because of the site or anatomy of the middle ear closely adjacent to the main structure, so it can develop many complications. Next. So yeah, for example, acute mastoiditis, the infection of the mastoid bones, which is located posterior to the middle ear, and then subperiosteal abscess, facial paralysis, because the facial nerve also cross through the middle ear and also mastoid bone, and then suppurative labyrinthitis, when the labyrinth is infected, so the patient might present with acute vertigo and also sudden hearing loss. And then other things, acute petrositis, and then intracranial or meningitis. Even the worst case scenario, which is patient can develop intracranial brain abscess. Okay, next. Okay, so moving on to the how we treat the suppurative otitis media. So usually we treat medically, and then rarely patient will need the surgical intervention. So most of the time we treat as outpatient by giving the oral antibiotic. But if it is child and then the parents are worried, so we might admit for the IV antibiotic. So the systemic, we give systemic antibiotic, which is the augmentin, about for 7 to 10 days. Or we can give cefuroxime or erythromycin. So if there is no improvement, if in the next 2 to 3 days, so it will may require the tympanocentesis, which we make a hole in the tympanic membrane to drain the mucopurulent discharge from the middle ear. And then, usually the perforated tympanic membrane, it should be normal within 2 to 3 months, if in the event of no recurrent infections. And then other things, we also can give the antipyretics for fever, analgesia, IV fluids, and also ear tolerating to move away the pus. And then if the patient also, still present with nasal congested or rhinorrhea, so we can give a systemic or oral nasal congestant, which is antihistamine. Yeah, and then or maybe topical nasal congestant. Next. Okay. Like I said, rarely we treat rarely the patient will need the surgical intervention. However, we some of the indication for the tympanocentesis, which is severe otalgia, toxic child, persistence of infusion more than 3 months, newborn, and if the patient have the complication, we also might need a cortical mastoidectomy, for example, in the mastoid abscess. Okay, last slide. So this one what I have mentioned, the treatment. Okay, proceed to the second presenter.
Okay, Assalamualaikum. Can you hear me?
Yes.
Yes, we can.
Okay. Ibrahim, can you present the slide? Thank you. Okay. Today, this night, I will talk about the chronic suppurative otitis media. So, next. Okay, this is my outline, which is we start with definition, epidemiology, pathophysiology, and also classification of chronic suppurative otitis media. And also clinical feature, and also examination and diagnosis, and the last one is management. So we proceed next. Okay, so this is actually the anatomy of tympanic membrane. As you can see, this is a normal tympanic membrane, which is we need to know the normal one, so we can differ with the abnormal one, which is the pathology of tympanic membrane. So as you can see this is you can see the anatomy of tympanic membrane, which is this upper, which is a pars flaccida, cone of light, and also partesa and umbo in the incus, and also the short of process of Malleus, and also membrane of Malleus. So proceed to the next. Okay, so I will talk about the definition of chronic suppurative otitis media, which is CSOM. So it is actually defined as a perforated tympanic membrane with a persistent drainage, which is we call otorrhea, from the middle ear for more than 2 and 6 weeks. That's why we call the chronic, which is they more than for 2 weeks. Okay, so it can occur with or without cholesteatoma, and also the clinical history of both condition can be very similar. So okay, for the next one. So as you can see in the estimated about 31 million new cases per year worldwide, and also it also same as acute uh, suppurative otitis media, which is common in infant and children of lower socioeconomic status. Yes, because they doesn't have money to uh, get what we call the medication or treatment. Okay, so we can see for the risk factor of the chronic suppurative otitis media, which we can see is actually the patient have a history of multiple episode of acute otitis media, so it can lead to the chronic, and also early otitis media. And the next one is chronic security otitis media, and also some additional risk, which is crowded area, frequency upper respiratory tract infection, and also comorbidities. So proceed next one. Next. Okay, turn back. For the pathophysiology. Okay. So how chronic suppurative otitis media happen? So actually the pathophysiology is complex and also multifactorial, which is involve many causes, such as involve bacteria infection, and also environmental, and also the host factor. So it actually initiate by episode of acute infection, and also inflammation. So it begin with irritation and also subsequent inflammation of the middle ear mucosa. So when they have a progression, and the inflammation response is still progression, doesn't have a healing process, so it will respond to create mucosa edema. So when they create mucosa edema, it will lead to the ulceration, and also it will break down to the epithelial lining. So lastly, it will create the pus. Okay. So next. Next we talk about the classification of chronic suppurative otitis media, which is actually divided into type, which is tubotympanic disease, and we call TTD, and also the eticoenteral um, disease. So actually we can see between the differential between the discharge, perforation, and also granulation, and also the polyps, and also the cholesteatoma, and also the complication. So as you can see, the discharge for the tubotympanic tubotympanic type is actually safe type. So you can see the discharge is all profuse, mucus, and also odorless, which is not really smell. And for the ethical entry is actually unsafe type, which is we can see the discharge is scanty, purulent, and also for smelling. So for the next, which is the perforation, as you can see, this actually we need to know about the anatomy of tympanic membrane. That's why it's important to know about the anatomy because we can differentiate between the tympanic and also eticoenteral. Because tympanic membrane is actually occur in the central, which is actually occur in tympanic cavity. And also the eticoenteral it occur in the atic or marginal side, which is the mastoid segment. Maybe after this, I show the what we call the picture. You can see, and also for the granulation, for the tubotympanic is uncommon, and also for the eticoenteral is common. So we can see the polyps, which is for the tubotympanic is pale, and also eticoenteral, which is red and fleshy. So it's actually, as I mentioned, that CSOM can occur with cholesteatoma and also without cholesteatoma. So this is differential between the type of tubotympanic and also eticoenteral. So for the complication for the tubotympanic is rare, but eticoenteral is common. So the last one is audiogram, which is you can see for the tubotympanic type, which is mild to moderate and also conductive distress. And also the last, which is eticoenteral, which is conductive or mixed stiffness. So next, Ibrahim, can you move to the next slide? So this is picture of tubotympanic type. As you can see, it's actually the perforation is occur in the middle, in the center. As you can see, the big one, this one. Okay, so we can see what we call the cone of light. The cone of light is absent. So this is type of the tubotympanic type. Next. So for the anticoenteral type, as you can see, it's occur in the atic segment and also the posterior segment of this cavity. Okay, next. So the clinical feature, which is the patient got what we call hearing loss because it's affected the tympanic brain, so tympanic membrane. So the patient got hearing loss, and also the otorrhea. Otorrhea is actually common the patient because yes, chronic suppurative otitis media have a discharge. So some patient have a fever because of the infection, and also the patient will get the vertigo. Okay, so next. So how we want to examination for the patient got CSOM. Actually, we can see it's revealed that tympanic membrane with perforation and also the purulent or discharge in the middle ear. So we can see the discharge can range. We can range from the purulent to fatigue or fatigue to cyst-like, and also the discharge can fill the ear canal. So we can see the presence of cholesteatoma, And also we can see the retraction of the pocket of the tympanic membrane, which is invasion of tympanic membrane that we can see at the attic and also posterior superior part. Okay. So next. So for the next, which is investigation, or we want to diagnose that for the CSOM. So as I mentioned of ear under microscope, which is we can see the cholesteatoma, which is the site of the perforation and for the extent, and also they have a bone destruction and also granuloma, and we can see the pocket of discharge. So we need to investigate using the tuner fork or audiogram because we need to know about uh, how severe the hearing loss, and also we need to have a culture and also sensitivity of the ear discharge because we don't know what bacteria can give infection to the corneas, such as otitis media. So we need to culture it so we can know what is the bacteria in the culture. So the last one, we use imaging, which is X-ray or the mastoid, and also CT scan for the temporal bone. We use for the CT scan because CT scan is what we call it's good for the bone screening. Okay, compared to ultrasound, which is ultrasound is soft for soft tissue. MRI is for the soft tissue. Sorry. Okay, next. So the last one is the management. Management for the CSOM, we can do the surgical, which is sorry, I typo, which is mastoid. Wait. Mastoidectomy. Okay, mastoidectomy, which is they have two type, which is canal down procedure and also canal walk up. So we can do surgical for the reconstructive surgery such as meningeoplasty and also tympanoplasty. So for the tympanoplasty, we uh, we reconstruct the perforation of the tympanic membrane. So the meningeoplasty, we also repair the tympanic membrane, but we use a graft material, which is the graft material will replace the missing of the fibrous element of the tympanic membrane, which is the perforation one. So it close the tympanic, what we call the perforation there. So I think that's all from me.
Bisa.
Mm-mm.
So any questions before I start asking questions? Any questions from your colleagues?
My question is between the acute and chronic, except the duration, is it the symptoms same or not?
Anyone can answer it? So what the difference between acute and chronic beside the duration? Presenter?
Wait. wait.
Cepat.
Okay.
So, jawapan tak? very good questions. Jawab tak ni?
I'm not sure, Doctor. I just finding.
You are trying to Google, is it?
Yes.
Alright. So basically, generally when you are discussing about acute versus chronic, one is the duration, is true, very true. The second one is the symptom is slightly different, the presentation. Okay, in acute otitis media is usually related to infections, right? Either it's bacterial or viral infections. Whereas in chronic otitis media, it's not always due to infections. So chronic otitis media, majority, you can say almost 99%, they will have a TM perforation. Whereas in acute otitis media, the TM is still intact. Okay. So because of this because of this TM perforation, there is a chronic irritation to the air, external air. So your medial ear mucosa, we have start producing this fluid or secretions. So that's why they will have this chronic discharging ear. Understood? Whereas in acute otitis media, after the infection resolves, majority of them will heal by itself, especially in pediatric age group. Okay. So unless patient have multiple episode or recurrent episode of acute otitis media, then they can lead to chronic otitis media. So because of this, clinically, your acute otitis media, the TM is intact, whereas your chronic otitis media, the TM is perforated. That's why in initially presentation of acute otitis media, they won't present with ear discharge. You present with ear fullness, fever and ear pain. Compared to chronic otitis media, they will present with generally majority chronic ear discharge without ear pain, plus minus ear fullness. But can chronic otitis media have ear pain? Yes, when they have a secondary bacterial infections. Understood?
Understood, Doctor.
All right. So chronic otitis media usually associated with those who are yang kuat berenang, swimmers and everything. Because of the connotation for your punya, beside air is water. Ada you mandi ke, your mandi sungai ke, whatever. Okay. So that's why when you advise the patient, it's different. Even the management itself is different actually. Okay. For acute otitis media, it's almost always related to bacteria. That's why we'll cover with oral antibiotic. And because the TM is intact, there is no point you give ear drop because the disease in the middle ear. It's not the external ear. Understood?
Understood.
Okay. And at the same time, AOM is usually highly associated with your punya external infection for your nasopharynx. So that's why, or your nose. For example, those of urinitis, post-UTI, that's why when we treat patient with acute otitis media, we also have to treat the nose. No point if you treat the ear, but you don't treat the nose. Patient represented with recurrent ear pain. Okay. So, majority of acute otitis media is conservative. You can even treat as outpatient unless there is a complication. Right. So your complication, how to remember is quite easy actually. Either it's local or systemic. When you say about local, if you know the anatomy of middle ear, the boundaries, then you can assume what is the possible complication. For example, if you imagine your middle ear like a matchbox kotak, in a lot of books will describe it as a matchbox. Okay, so the roof itself is your segment or your basal skull. So any chronic infection, they can lead to intracranial punya infection. Ada your meningitis, temporal abscess, or encephalitis. Okay. If we extend posteriorly, your posterior is your mastoid. So in acute media, repeated acute media can lead to mastoiditis or mastoid abscess. Medial, the middle of your medial ear is promontory, which is your basaltin of cochlea. So there's a possible to have this labyrinthitis. Right. So from the lateral wall is your TM. So at the stage, any other stage, the complication is TM perforation. So when you have patient presented with acute otitis media, these are the things that you need to explore when you ask question, when you examine the patient. Okay, understood. If there is any evidence of complication, then the indication for admission, IV antibiotics. Okay. So when do you actually do a surgical intervention for acute otitis media? Your colleague mentioned about tympanocentesis, is it?
Yes, Doctor.
Okay. So I assuming you are using a Dingra book, am I right?
Yes.
Indian based book. Okay. So we don't use the term of tympanocentesis here, but we do use the term of meningotomy. So there are cases we have to do some surgical intervention. For example, your meningotomy, in which one, when patient have very severe intractable pain because of pressure, because it's closed space, right? So because the TM is intact and there's a lot of circulation with edema, so patient will have a severe ear pain, intractable ear pain. Then yes, we can use a meningotomy with or without grommet. Either we just nick, remove, suck the whatever circulation inside there. After that, we can put grommet to improve the ventilation, or we don't put. It depends. Okay. The other indication is if patient develop facial palsy. Okay. So in acute otitis media, okay, your friend mentioned that there is a facial nerve in your tympanic, in the medial ear, which is your tympanic segment. Am I right? So this facial nerve is by right is covered by a bone, what you call a fallopian canal. However, I think about 30% of the population, they have absence of this fallopian canal. So there is no bone coverage of your facial nerve. So there is a possible of neuritis, and patient can develop a facial palsy. Okay, but be careful. One of the causes of acute otitis media is congenital cholesteatoma. So congenital cholesteatoma, they were presented like a chronic otitis media because the criteria for congenital cholesteatoma is one, the TM must be intact. Second, you can see a whitish spur behind the intact TM. And then patient tak ada pernah no history of ear discharge and no history of ear surgery. So this group of patients, they can present with recurrent AOM with facial palsy, especially in children. So that's why kalau patient children presented with acute otitis media with complication, we must rule out congenital cholesteatoma. Understood? If you have question, you can ask. You can ask me to repeat if you are confused. Because it's already 10:30, 10:40. If I keep asking questions, so you can delay until 12. All right. So might as well I just spoon feed you guys. Okay. All right. So what about other surgical intervention? Okay, there is other surgery. For example, you mentioned about mastoidectomy. You have canal wall up and canal wall down. Okay, good. You mentioned about mastoidectomy, canal wall up and canal wall down. There are few types of canal wall down procedure and canal wall procedure. Okay, I won't go into detail because it's too advanced for you guys. So generally, if it's developed complications such as mastoiditis, acute mastoiditis and not chronic mastoiditis, acute mastoiditis or mastoid abscess, you must do a canal wall up procedure or cortical mastocytomy. If there is evidence of cholesteatoma, this is basically when you do CT scan. After we do CT scan, then if there is evidence of cholesteatoma, then we have to do a radical mastocytomy or modified radical mastocytomy. Understood? So the difference is one, when you say what canal wall up and canal wall down, what makes different is that the posterior wall EAC. In canal wall down, we bring down the posterior wall EAC so that the EAC and the mastoid become one common cavity. Boleh imagine You guys can imagine? Are you guys listening or are you guys sleeping already?
Listening, Doctor.
Right. So if you cannot imagine, then tomorrow I will draw and show you. Okay. Just remind me tomorrow. Okay. So, okay. So these are the things you can mention. Okay. In acute otitis media, is there any role for MRI or not? Yes, this guy is the best because he can give us a very good bone window. You can see the ossicle, you can see the cochlea, you can see the mastoid, you can see the tegment, a lot of things you can see. But is there any role for MRI or not? In acute otitis media with complication? If yes, in what condition? MRI. Something? Boleh repeat?
If patient have intracranial brain abscess.
Good. When there is intracranial complications such as your meningitis, your abscess, your encephalitis, because these are soft tissue in which MRI is superior. Right. So if you expect there is intracranial complication, you must do a CT scan with MRI. Okay. All right. Good. So far, any question about AOM, acute otitis media? Tak ada? Okay. Now, we are talking about chronic otitis media. Okay, true. In textbook, especially the most of the Indian-based textbook, they will mention about arterial enteral and tubular tympanic. They use the term chronic suppurative otitis media. But nowadays, we don't use that term already. We only use chronic otitis media without cholesteatoma or chronic otitis media with cholesteatoma. These are the terms that we are using now. Why? Because it makes difference. The management is different, the outcome is different, the complication is different. Okay? So we are using chronic otitis media without cholesteatoma, chronic otitis media with cholesteatoma. Okay. That I mentioned just now. Chronic otitis media is not always associated with infection. That's why chronic otitis media, they only presented with persistent ear discharge, maybe ear fullness and ear hearing, but they won't present it with ear pain, or they won't present it with fever or headache or whatever, or they won't present it with complication. Unless one, when there is a condition what you call acute on chronic otitis media, mean he have a chronic discharging ear, but he has a secondary bacterial infection or viral infection that leads to acute infection. Then patient is presented with ear pain, fever, and possible whatever complication. The similar like acute otitis media. Okay. But this thing is applied under chronic otitis media without cholesteatoma. Okay. In the case of chronic otitis media with cholesteatoma, there is a bit of difference. Okay. One, both represent, I'm talking about chronic otitis media without cholesteatoma, chronic otitis media with cholesteatoma. Okay. Chronic otitis media with cholesteatoma, both of these two things represented with chronic ear discharge. But in chronic otitis media with cholesteatoma, the term of discharge is called a scanty ear discharge. One. Second, if you smell it, it's like a dead fish smell. It's very smelly. Okay? And third, the hearing wise is generally is worse compared to the one is without cholesteatoma. Therefore, most of the time, this chronic otitis media with cholesteatoma, we can see a keratin debris within the external ear canal or middle ear cavity. Understood? So far, any questions? Okay.
Doctor,
Hmm.
so we divide chronic otitis media into with and without cholestoma.
Yep.
But how about the type active and inactive?
Okay. In chronic otitis media, without cholesteatoma, inactive means there is no ear discharge. It's a dry ear. Even though there's a perforation, but it's a dry ear. Okay. In chronic otitis media with cholesteatoma, without any surgical intervention, it won't become inactive. It will keep discharging no matter how much you drop, no matter how much medication you give, unless we remove the cholesteatoma. Okay. In chronic otitis media without cholesteatoma, active means is keep discharging. Keep on discharging, keep on discharging, keep on discharging, despite patient compliance to ear care, despite you try to control the whatever nasal symptom, despite you are giving optimized medical treatment, patients still have a chronic discharging ear. That means active. So active can be both, either acute infection or non-infection, just inflammation. Faham? Okay. All right. Any more questions?
Doctor, you said that the hearing is worse in chronic otitis media with cholesteatoma. But on the other day, you explained about the bridge effect.
Okay. Now, when talking about the bridging effect is, okay, in chronic otitis media with cholesteatoma, the hearing can be either pure conductive, mixed or pure sensory, right? In the case of early cholesteatoma or minimal active disease, mean the very minimal cholesteatoma disease, so usually they won't have a sensory component. They will have a conductive component because they will affect the occipital first, which is the incudiomalleus joint, because this joint is an arterial organ. So this joint will be affected first in chronic otitis media. That's why in initial PTA, you can see there's a bone gap. So they will have a conductive hearing loss. Okay. But because of this bridging effect, the amount of hearing loss is not equal to the severity of occipital loss. For example, in cases where the all occipitals are eroded, but the conductive hearing loss is the bone gap is about probably 20-30 dB. The bone gap. But after you remove the cholesteatoma, once you repeat the PTA, we can see the bone gap become larger. From 20 to 30 dB, it can become up to 60 dB because the loss of bridging effect. So this bridging effect is not actually to compare with the one without cholesteatoma. It's just to explain why in patient with cholesteatoma, after the surgery, the hearing can be worse. Understood?
Yes, but just to confirm, doctor, so the hearing will be worse in case of late presentation of CMO.
Cholesteatoma, when you compare to chronic otitis media, if you take the same duration, for example, 6 months, the amount of damage in cholesteatoma is worse compared to chronic otitis media without cholesteatoma. Okay. Because cholesteatoma is not only because of that disease alone that lead to a chronic inflammation of your nerve. I did ask you guys, right, about how cholesteatoma develop all this complication, about the secondary bacterial infection, about the cytokine, about the interleukin, everything, right? So yes, because of these things, it makes the risk of hearing worse compared to those who are without cholesteatoma. Understood? When comparing in the same window period, for example, 3 months and 3 months.
Okay, understood, Doctor.
Okay.
Okay.
Okay. So, in chronic otitis media without cholestoma, what is or are the indication to do a mastectomy? In chronic otitis media without cholesteatoma, in which condition we will offer patient for surgery? I mean, mastectomy or canal wall up procedure. In what condition? Anyone?
Otorrhea,
Well, they will have otorrhea definitely.
which persists despite antibiotic use.
How long?
More than 6 months.
So it's a persistent ear discharge despite optimized medical treatment more than 3 months. In these cases, we can discuss patient with the options of mastectomy because patient may have a chronic mastitis. It means that the source of this ear discharge is because of the chronic infection of your mastoid bone. There's a lot of granule tissue, whatever inside there, that leads to chronic discharging ear. Okay, understood. So, one. Second, in patient with acute on chronic otitis media with complications, they still can have mastoid abscess. They can still have intracranial complication. So, in this type of cases, then there's also a role for mastectomy or canal wall procedure. Understood?
Okay.
Faham tak?
Yeah.
Okay. Again, in chronic otitis media without cholestoma, when can we offer patient for laryngoplasty or tympanoplasty? When can we reconstruct the tympanic membrane? In the case of chronic otitis media without cholesteatoma.
And first is when there is persistent otorrhea more than 3 weeks.
This what? Persistent
Sama
otorrhea?
dengan tadi, Doctor.
Okay. Again,
When
my first question is about mastectomy or canal wall up, right? My question now is, when can we do a tympanoplasty or laryngoplasty or TM reconstruction? It's different procedure and different aim.
when they have a big perforation at the center.
Definitely chronic otitis media without cholestoma, we have operation. Okay.
When ear is dry.
Good. How long the ear is dry? How long you have to wait? The duration, okay, this is considered as dry ear. Then we can suggest for this laryngoplasty or tympanoplasty. Minimum 6 weeks of dry ear. So minimum 6 weeks of dry ear, then we can offer a laryngoplasty. The aim is not to improve the hearing. Although there is studies that if you do tympanoplasty, you can reduce the airborne gap up to 20 dB. The reduction of airborne gap. But our aim is not to improve the hearing, but is to create a safe and dry ear. Because like I mentioned just now, in chronic otitis media, it's not usually related to infection, but due to exposure to the room air or whatever water goes into your ear. So the aim is to create a safe and dry ear rather than to restore the hearing. Restore the hearing is secondary intention. May or may not have the patient. So when we discuss with patient, we must emphasize that if you do laryngoplasty, we cannot promise the hearing can be better. It may be the same. Okay. Understood? Any questions? Any more questions you guys want to ask? Okay, if there is no more questions, ada ke soalan?
Doctor, I have a question. For the chronic, it said that the patient has perforated TM. Does the TM heal by itself?
Okay. Chronic means that is chronic discharging ear. In a chronic discharging ear, there will a lot of inflammation occur. Because of this, it's almost impossible for your TM to heal. In any of inflammation, one of the complications is fibrosis. Am I right? So because of this, the ring, the perforation, the ring or the perforation will become fibrosis. So when it fibrose, it won't heal. That's why chronic otitis media, they will have a perforation. Either it's dry or not, they will have a persistent perforation. Unless in acute otitis media, then there is a possibility or chances for it to heal, provided one is the perforation is small, second it's been treated early, and there is no episode of recurrent AOM. Okay. Am I clear?
Clear, Doctor.
Okay. Any more questions? Okay, if there is no more questions, we can end our session for tonight. If suddenly you tidur, you mimpi ada soalan tanya, then you can ask me tomorrow morning. Inshallah, I will be around. Good job on presentation. On the presentation. Although you're using the chronic media term, you are still using the old term, and actually you are not wrong because you are following textbook. Okay. So, but now we are changing. Actually, it's been changed the last few years. Okay. In OSCE, we can ask a picture of otoscope findings and ask you to describe. We can ask you about giving a diagnosis and then how you manage. We are not strict in marking paper for undergrad. Okay. But there are certain things that's unforgiven sin. Mean that if you write that, it's definitely 0. You cannot even give half marks. And to be honest, if you can deduct your mark, I will deduct your marks. Okay. So, it's ideally do not leave any question unanswered. But please don't answer it wrongly lah. Jauh sangat menyimpang. Right? For example, last batch, kita letak gambar nasoendoscope. I think about 1/3 of your punya colleague answer is laryngoscope. So, cannot do anything, cannot help anything at all. So, 0 lah ke? The whole question 0 marks. Alright, okay. So, I think that's all. We can end our session. Okay lah, Assalamualaikum warahmatullahi wabarakatuh.
Okay, thank you, Doctor.
Salam.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.